All right, let's jump right in.
Sounds good to me.
Today we're diving deep into the world of critical care and tackling a challenge.
Oh,
A
yeah.
challenge that's both complex and crucial.
Uh-huh.
And that's figuring out the best way to determine the right dosage of antibiotics for patients.
Right.
Patients who are battling sepsis.
Sepsis is, it's kind of like a domino effect, a really dangerous one that happens when your body overreacts to an infection.
I see.
And that overreaction, it can lead to widespread inflammation.
Oh, wow.
And even organ failure.
So it's like a fire that's just spreading through the body.
That's a good way to think about it. And
Oh, wow.
just like putting out a fire, time is really important.
Right.
Antibiotics are often that first line of defense.
Okay.
And today, we'll be focusing on a type called beta-lactams.
Okay, so beta-lactams, those are like
Right.
the go-to in these kinds of situations.
Exactly. They work against a wide range of bacteria. Generally safe, have a good safety margin
Okay.
when it comes to dosage. But figuring out that right dose in a really sick patient
Yeah.
isn't as easy as it may seem.
So it's not just like a one-size-fits-all kind of thing, what makes it so tricky.
So we have this idea, this concept called the minimum inhibitory concentration,
Okay.
or MIC.
Oh, my.
Basically, for the antibiotic to work, it needs to be strong enough, concentrated enough in the body
Okay.
to actually stop the bacteria from growing. And with these really sick patients, there are all sorts of things that can throw off that balance.
Like what kind of things?
Well, think about it. Their organs
Right.
might not be working properly. They could be on other medications.
Okay.
Their blood volume could be all over the place.
Oh, I see.
All of these things affect how their bodies deal with the drug, making it tough to know how much of that antibiotic will actually get to the infection and stay there long enough to do its job.
So even if you give what's considered the standard dose,
Yeah.
it might not be enough to really...
You've got to take care of the problem.
And in sepsis, where every minute counts,
Right.
that can be a big problem.
That makes a lot of sense. And this is where I think Dr. Garrido's work comes in.
Yeah.
Right? He's been really looking into this whole idea of optimizing antibiotic dosing.
Absolutely. And he really, really emphasizes how important it is to start treatment fast. He says that every hour you wait to get those antibiotics in can really reduce a patient's chance of survival.
That's it.
It's a big deal.
Yeah, that's a really powerful statement.
For sure.
It really makes you realize how urgent the situation is.
It is. And he uses that analogy of a wildfire.
Yeah.
You know, the faster you can contain it,
Right.
the better.
Yeah.
Same with sepsis.
But getting that initial dose right
Yeah.
seems like it would be really tough.
With all the factors
It is.
we've been talking about.
Yeah. It often feels like a shot in the dark.
So how do doctors even approach this?
Well,
I mean, do they just have to use their best judgment and
not just guesswork.
hope for the best?
They use their experience and their clinical knowledge.
Right.
But there's a whole science behind how drugs work in the body.
So you're talking about pharmacokinetics,
Pharmacokinetics,
and pharmacodynamics. Okay.
So pharmacokinetics is all about what the body does to the drug. How it takes it in, spreads it around, breaks it down, gets rid of it.
Okay.
And pharmacodynamics, that's about what the drug does to the body,
I see.
how it attacks those bacteria.
So doctors need to think about both sides of that.
Yes.
How the patient's body will affect the drug and how the drug will affect the infection.
Exactly, and it gets even more complicated. When you remember that these really sick patients don't always follow the textbook.
Right, and Dr. Garrido had some really interesting examples in his presentation.
Yeah.
He talked about how changes in kidney function,
Oh, absolutely.
which are pretty common,
Yeah.
can really impact
Yeah.
how quickly an antibiotic is cleared from the body.
He did. He specifically mentioned meropenem, which is a common beta-lactam,
Right.
and pointed out that the clearance of that drug is directly tied to creatinine clearance,
Okay.
which is a measure of kidney function.
So if the kidneys aren't working well,
Right. The drug might stick around
oh, wow,
a lot longer
longer than you'd want.
than expected. Yeah.
And then you've got things like fluid buildup,
Yeah.
which could dilute the concentration.
Absolutely.
He also mentioned low albumin levels,
Yes.
which can also mess with how the drug binds to proteins in the blood.
It's a balancing act for sure.
There's a lot to keep track of.
It is. Yeah. And then on top of all that, you have treatments like dialysis, which is essentially filtering the blood, and that can actually remove antibiotics.
Oh, wow.
More quickly.
So you're constantly having to adjust and recalibrate.
Yeah.
It's amazing how much goes on behind the scenes.
It is.
To keep those antibiotic levels right where they need to be.
It is.
It sounds like a real high wire act.
It is. It's a constant tightrope walk.
Yeah, it really is incredible.
It is. It really is.
How they manage to keep all that in mind.
Right.
When they're making these decisions about dosage.
You know, and all of that assumes we even know the right dose.
Right.
Dr. Garrido, he made a good point. Sometimes where that infection is can actually change how much antibiotic you need.
He gave that example of like an infection in the central nervous system being harder to treat than, say, like a lung infection. Because it's harder for
some parts of the body are harder to reach.
For the antibiotic to get to.
Exactly. And then on top of that, you have different bacteria have different susceptibilities.
So some are just naturally tougher. Yeah, some are just tougher.
Okay.
And need a higher dose.
So it's not even just the patient, it's also the...
It's the infection itself.
Yeah, the infection itself.
Yeah.
Wow. So it's like this whole puzzle.
It is, yeah.
That they have to solve.
And then, to make things even more fun...
More fun? Oh, no.
There's this thing called the inoculum effect.
The inoculum effect. What is that?
Okay, think of it this way.
Okay.
You've got a small campfire.
Okay.
Versus a huge raging wildfire.
All right.
Which one needs more water?
The wildfire.
Same with bacteria. More bacteria can actually make them tougher.
Oh, wow.
To kill.
So it's almost like they're protecting each other. Yeah, all clumped together.
It really shows you how important it is to catch these things early.
Absolutely. The faster you get those antibiotics in there, the better.
The better. So it all comes back to...
It all comes back to early aggressive treatment.
Yeah.
Like Dr. Garrido said.
So we've got the patient, we've got the infection.
We got the inoculum effect.
The inoculum effect. This is a lot.
It is.
But Dr. Garrido mentioned a potential game changer.
Yeah, he did.
Therapeutic drug monitoring.
TDM.
TDM.
Tell me more about that.
So how does that work?
So basically, you measure the level of the antibiotic in the patient's blood.
In their blood.
Yeah, so you can see if that dose...
So you're not just guessing.
Not just guessing.
You're actually seeing.
You're actually seeing what's going on in that patient.
That seems so valuable.
It is super valuable.
With all the different factors.
It is, yeah.
You've talked about.
Dr. Garrido is a huge fan of it.
Okay.
And he gave a really good example.
Oh, yeah.
He was talking about the antibiotic Beta-Lactam.
I've heard of that one.
Yeah, and at first, the recommended doses... they were too low.
Oh, wow.
Which unfortunately led to higher mortality. Yeah. It wasn't until they started using TDM that they realized, whoops, we need to up the dose.
So it really does.
It really does.
It makes a difference.
It makes a huge difference.
Now, are there other strategies that they're looking at besides TDM?
There's a lot of research going on.
Okay.
People are trying to find new ways to predict and monitor those levels.
Okay.
Some folks are working on these computer models.
Oh, wow.
That take into account all those patient variables.
So almost like...
Yeah, almost like personalized medicine.
For antibiotics.
For antibiotics, that's right.
That's amazing.
And then there's other research looking at different ways to give the antibiotics.
Right, like the...
Yeah, like continuous infusions.
Continuous infusions.
Yeah, where it's a steady dose.
Versus the
intermittent dosing.
Yeah, I remember him saying that might be...
He thinks that might be...
more effective.
More effective, yeah.
To keep that steady level.
Keep it steady.
So we've talked a lot about bacteria and antibiotics.
We have.
But what does all this mean?
That's a great question.
For those of us who aren't doctors, why should we care about all this?
I think it's important to understand this stuff because it helps us really see the challenges that medical professionals deal with.
Every day.
Every single day.
It's easy to think that giving an antibiotic is just like...
Yeah, it's just routine.
Simple thing.
Yeah, but it's so much more.
It's so much more than that. It makes you realize...
There's this whole world of stuff going on.
Behind the scenes.
Behind the scenes that we never see.
Yeah, and speaking of behind the scenes, Dr. Garrido's proposed observational study.
Right.
Can you remind us what he's hoping to learn?
So he wants to understand better. How well current practices are working.
With the antibiotics.
With the antibiotics, yeah.
So he's not going to change anybody's treatment?
He's not changing treatment, no.
But he's
just measuring levels to see if they're hitting that sweet spot.
So seeing if what we think is happening is actually what's happening.
Exactly.
What happens if he finds that it's not?
Well, that's where it gets really interesting.
Okay.
That could be the evidence.
Okay.
To support using TDM more widely.
I see.
Or other personalized dosing strategies.
So his findings could really change things.
They could change guidelines. They could change how hospitals approach all this.
So Dr. Garrido's work could really...
It really could.
Help improve patient care.
For sure.
It's great to see research pushing the boundaries. But I imagine doing a study like that in the ICU.
I imagine.
Must be really challenging.
Yeah, I bet there are a lot of hurdles.
I mean, it's not like you can just...
It's a sensitive environment.
Yeah, have people to fill out a survey or something.
Yeah, exactly. These are
people who are...
People who are really sick.
Really sick, yeah.
You're right. Doing research in the ICU.
Yeah.
It's a balancing act, for sure.
So what are some of the things that they have to consider when...
Well, first off, informed consent is super important.
Of course.
Even though Dr. Garrido isn't changing anyone's treatment.
Right.
He still needs permission to take those blood samples.
I imagine that's a tough conversation.
It is. You're talking to people.
Yeah, when someone's...
who are in a crisis.
Yeah.
Dealing with a lot of stress.
Yeah, a lot of uncertainty.
It takes a lot of sensitivity.
Absolutely.
To explain everything clearly.
So building trust is really...
Trust is key.
Yeah.
You're asking them to help. Advance medical knowledge.
To help other people down the road.
Exactly.
Right.
But you also have to understand...
They're worried about themselves.
Yeah, their immediate needs.
And I imagine there's also
a
lot of logistical stuff.
Lots of logistics.
Yeah.
The ICU is busy.
Busy place.
Fast-paced.
Can't disrupt what's going on.
You can't just barge in and take a sample whenever you want.
Yeah.
You need trained people to collect those samples correctly.
Right.
You need to keep track of everything.
Right.
Label everything properly.
All the while making sure.
And then the lab needs to process them.
Yeah.
And of course, patient safety.
Patient safety.
Is the top priority.
It sounds like it takes...
It's a real team effort.
A village.
Researchers, doctors, nurses.
Wow.
Lab staff, everyone.
So let's say he's able to pull this off.
Yeah.
He gets the study done.
What happens next?
What happens next?
Yeah. Well, if he finds that there's a big difference between what we think is happening and what's actually happening.
With those antibiotic levels.
With the levels,
Things could really change.
That's when things get exciting.
Yeah.
It could be the push we need to change practice.
You get people to use TDM more.
Use TDM, change guidelines.
Maybe come up with new dosing recommendations.
Maybe even spark new research.
So Dr. Garrido's study could really...
It could be a real catalyst.
Be a catalyst for change.
Yeah.
That's pretty amazing.
It highlights how important it is to keep asking questions. To keep looking for ways to improve.
Right, to not just assume we know everything.
Research isn't just about ideas.
Yeah.
It's about actually impacting lives.
Making a difference.
Absolutely. And that's why we do this.
Yeah.
We dive deep.
Dive deep into these topics.
To see how those discoveries connect to the real world.
And the challenges people are facing.
Yeah, the patients and the doctors.
Well, I think we've covered a lot today.
I think so.
Learned a ton.
I hope so.
About sepsis, about antibiotics.
It's a complex world.
It is.
But it's a fascinating one.
Any final thoughts for our listeners?
Even something as simple as giving an antibiotic.
Yeah.
It's more complicated.
Than you might think.
Yeah,
it's not one size fits all.
It's not. It's about recognizing that each patient is different.
And that's where research can help.
That's where research shines.
Absolutely.
It helps us personalize treatment.
Right. And ultimately,
it's better for everyone.
Improve outcomes.
Exactly.
All right. Well, on that note.
Sounds good.
We'll bring this deep dive to a close.
Thank you for listening.
But as always.
Keep exploring.
Keep exploring.
Keep asking questions.
Keep asking questions.
And keep diving deep.
And keep diving deep.
Into the world around you.
We'll see you next time.